Hello, this is Mrs. Castillo, and I will be lecturing on Unit 8A, Self-Expression for Men. We will start with benign prostate hyperplasia, which is also known as BPH. Remember that the prostate is a small gland about the size of a walnut and only exists in men. Its only function is that it produces secretions which are part of sperm. Unlike the liver, which is required in order to live, the prostate isn't an essential gland. It can therefore be removed under any circumstances without danger to life. Though there are problems related to the prostate, they tend to arise due to its anatomical location, which means that its removal can often cause urinary or sexual problems. BPH does not predispose a patient to prostate cancer, as prostate cancer begins in the outer part of the prostate and is the most common male reproductive system problem. The enlargement restricts the urethra so that the flow of urine is reduced, making it increasingly difficult to empty the bladder. Risk factors include family history, particularly involving first-degree relatives. Environment, if a person has low physical activity, high alcohol consumption, or is obese, can be a risk. Diet, usually high in zinc, butter, and margarine, is also a risk. But those that have a high fruit intake are at a lower risk. Thought to also be caused by changes in endocrine system as men age as well. Symptoms usually gradually are onset. The symptoms that you will most likely see or hear from the patient is hesitancy, which is difficulty in starting to urinate. Patients need to feel as if he has to strain to pass urine. This means there could be an obstruction. There is a feeling of incomplete emptying after urination, and that could be urinary retention, urgency or frequency. There is a frequent trips to the toilet at night, and dribbling at the end of the urination can also be a symptom. And there could be other symptoms just like dysuria, bladder pain, nocturia, and incontinence. Diagnostically, first we would start out with a history and physical as always. During the assessment, you want to ask questions about urinary passage. Then the doctor will do a direct digital rectal exam to palpate the dorsal surface of the prostate. The prostate is enlarged, firm, and smooth. That's what it should feel like. The examiner can estimate the size, the symmetry, and the consistency of the prostate gland. A urinalysis may be done. This may show bacteria. PSA will be drawn, and that's a serum test. It's prostatic specific antigen, and it might be slightly elevated. Serum creatinine will be elevated if there's kidney involvement only. They may do what we call a transurethral ultrasound, which is a probe to view the prostate. This can differentiate if the patient has BPH or prostatic cancer. You would only do this if you suspect something or if the physician suspects something. Uroflowmetry is a study that measures the volume of urine expelled from the bladder per second. It's helpful to determine the extent of the urethral blockage. A cystoscopy can also be done. That allows the visualization of the urethra and bladder. And again, that'll only be done if the doctor suspects something. Treatment expected outcomes. So after your treatment, this is what you expect to see: restored bladder drainage, relief of symptoms, prevent and treat complications of the BPH, and minimize urinary stasis, which can lead to UTI or kidney damage, as you know. Nursing diagnosis, usually acute pain would be your primary nursing diagnosis. Fear and risk for infection, ineffective therapeutic regimen management, and urinary urge of incontinence or hemorrhage can also be a nursing diagnosis. As the nurse, we need to evaluate the adequacy of the patient's voiding and determine if there is any urinary retention. We need to teach the client to avoid bladder distension, which can result in loss of bladder muscle. So they need to go to the bathroom every 2 to 3 hours. Teach patient to not postpone the urge to void. They should avoid drinking large amounts of fluid in a short period of time. Avoid alcohol because it can have a diuretic effect. And encourage a DRE annually for men older than the age of 40. All patients, though, over the age of 60 should be asked specifically if they are having any of these problems associated with BPH. Management. Watchful waiting if the symptoms are mild or none. The symptoms may come and go. They can also do some dietary changes, which is no caffeine or artificial sweeteners. Limit spicy or acidic foods. Avoid decongestions, antihistamines. They can cause urinary retention. Lifestyle changes, obviously a healthier diet, exercise, weight loss if needed. Time voiding. This reduces symptoms because the client goes to the bathroom every hour or whatever is best for the patient. And restrict evening fluids also. Kegel exercises are encouraged. This increases perineal muscle tone. There are some drugs that can be used. We start out with Proscar or Avodart, and it must be taken on a continuous basis to maintain therapeutic results. It's almost like Synthroid. When we take Synthroid, we have to take it on a consistent basis. This takes about 3 to 6 months to be effective. It reduces the size of the prostate gland. That's its main function. Alpha-adrenergic receptor blockers. This only provides symptomatic relief. It does not treat the hyperplasia. Most common you will see in the hospital or in the medical office is Hytrin, Flomax, and Cardura. It relaxes the smooth muscle. Now I will tell you with these medications, they do have a side effect of orthostatic hypotension. So the gentlemen that are on these, or patients that are on these, should be told to be careful when they're sitting up first thing in the morning. That they should sit up on the side of the bed, get their bearings, and then stand up, because it does have a orthostatic hypotension side effect. There are some herbal therapies. Saw palmetto. It's shown to improve urinary symptoms and flow. Long-term effectiveness and ability to prevent complications is really unknown. So it is important that you tell your patient to make sure they tell the doctor they are taking this. There are some minimal invasive therapies, which you don't really need to know too much about, but we will talk about the invasive therapy, which you'll see quite a bit in the hospital. Resection of the prostate, it is called a TURP. This is when we do a removal of the prostate tissue using a retroscope inserted through the urethra. There is no external incision. After surgery, the bladder is irrigated either continuously or intermittently, usually for the first 24 hours. And this is to prevent any obstruction formed from mucus or blood clots. You will see many of these patients on the urology floor. They will come back with what we call continuous bladder irrigation, or CBI. What's so important about this is that pain control is under control, and also that you keep the continuous bladder irrigation going and that you don't stop it. You may have to slow it down, but you should not stop it. Blood clots normally are within the first 24 to 36 hours, and because we're irrigating the bladder, they will have some bladder spasms, and that's what the pain is caused from. What we do here is we insert a catheter that has 3 lumens. One is, of course, for the balloon. The other is for the irrigation to go through, and the other is for it to drain back, the output back into a bag. So you will see this type of catheter. Usually you have to order it. It is not up on the unit. Then you'll see 2 large bags, irrigation bags, hanging above the patient, and you have to keep those well stocked in the room because the continuous bladder irrigation can run pretty quickly. You want to increase fluids to prevent any UTI. You will have some pink tinged urine. That's okay. But excessive bleeding may need to be looked at. There might be something going on in there that shouldn't be. So excessive bleeding you should not see. Encourage, well, first of all, they want to remove all the clots by irrigating. Then after the irrigation is off, the patients are encouraged to ambulate. They need to start practicing starting and stopping their stream, like Kegel exercises, which are the pelvic muscle exercises. Also, it's very important that you encourage them to drink lots of fluid. And after the catheter is taken out, they should urinate within 6 hours. And if they don't, the physician needs to be called back. More than likely, the catheter needs to be reinserted. There will be an open discussion that you need to have with the patient about sexual functioning. TURP doesn't usually cause problems, but it can, because remember the prostate does have it does have secretion. Dribbling after voiding is common, and it subsides after a few weeks. The patient should be encouraged to not strain, to have a high fiber diet and stool softeners. This will keep them from straining. High fluid intake to avoid UTI. Avoid caffeine as it may cause bladder spasms. Complications after surgery or after the TURP can be hemorrhage of the bladder. The bladder is very vascular. It's known the signs and symptoms. It's good to know the signs and symptoms of hemorrhage, which is larger than expected blood output. You will see an increase in heart rate, increase in respirations, and a decrease in blood pressure. The patient may also become very pale and short of breath. Make sure that if you are irrigating, that the output is larger than the input, because you're putting fluid in there, but you should be having urine out plus the clots plus the fluid that you're putting in, so it should be more out. Don't worry too much about pyelonephritis, UTI, and bladder stones. You're just worried about certain complications post-surgery. Prostate cancer is one of the most common cancers among men, second only to skin cancer. Most cases develop in men over the age of 65, and that's really important to know, the age factor. African Americans have the highest incidence. Their tumors are more aggressive, and they have higher mortality rates. Having a history of BPH is not a risk factor. Remember that prostatic cancer is on the outer part of the prostate. Slow growing, it is hormone dependent. It's the outer aspect of the prostate, which I just said. It can spread to the pelvic bones, to the femur, spine, liver, lungs. These are very common metastasis sites. It's very important that you start out with an assessment, a health history, and of course a physical. The rectal exam of the prostate shows to be, usually the prostate will be hard, enlarged, and fixed. There may be no symmetry of enlargement because of the nodule, so it may be asymmetrical. Pain of the lumbar sacral area may indicate metastasis to the bone. It's very common that prostatic cancer metastasizes to the hips or to the femur, to the legs. Remember, history of BPH is not a risk factor. Symptoms are very similar to BPH. Clinical manifestations are usually dysuria, hesitancy, dribbling, frequency, urgency, hematuria, nocturia, retention, interruption of urinary stream. It may cause inability to urinate. So again, these symptoms are very similar to BPH. PCA can also be elevated with aging. BPH also can cause a PCA to elevate a recent ejaculation, prostatitis, sorry about that. And long bike rides can actually increase a PCA, so it doesn't always mean cancer diagnosis. PSA, prosthetic specific antigen, is normally 0 to 4. It can also be used to measure success treatment when level falls. Treatment has been successful. So remember that if the PSA is elevated and then the doctor is taking it every month or so and it's going down, that means the treatment is working. A PAP might be done, a prostatic acid phosphatase, which is another blood test used to diagnose prostatic cancer. Of course, a digital rectal exam, of course, will be done. A TRUCE could be done, which is the transrectal ultrasound, and that rules out BPH versus cancer. A biopsy, if the prostate is enlarged or if the PSA is elevated. This is needed to definitely differentiate diagnosis. MRI CT can also be done, and that's just to rule out any metastasis. Now, conservative therapy, remember, it's watchful waiting. Care depends on the stage of the cancer. Early stages is curable. If it is decided to do watchful waiting, we do PSA levels and DREs yearly. 80% of the patients with prostatic cancer are initially diagnosed when the cancer is local. When it is diagnosed when the cancer is local, the cure rate is 100%. Now, there are some drastic treatments, but we'll start out with radiation therapy, also brachytherapy. Remember, when we talk about radiation therapy, you need to know the side effects of radiation therapy. Brachytherapy is usually when they put the radioactive seeds inside the gland itself. Surgical therapy, normally they'll go for a radical prostatectomy, and we'll talk about the complications here shortly. Don't worry too much about surgery. There are some hormonal therapy and chemotherapy that can be done as well, but we won't go into that too much. Nursing diagnosis, remember, identifying what the patient's complaint is how you would identify which nursing diagnosis you would go with. So you could start out with pain, acute or chronic, or skin integrity, or risk factors, that type of thing. Implementation, of course, you're supposed to encourage DREs and PSA screenings. Support for patient and family. Support groups are very good to get involved with, or encourage your patient to get involved with. Catheter care, if they end up having a permanent catheter or a catheter that long-term catheter. Encourage Kegel exercises, and of course pain medication. Testicular cancer. This is a tumor that occurs in males usually ages 15 to 35 years of age. It is the most common cancer in young men. Risk factors, of course, are undescended testicle, also a history of mumps, right testicular increased incidence, so on the right side there's more of an increased incidence. Family history of testicular cancer, inguinal hernias, like in childhood. Tumors of the testicles are often malignant and tend to be metastasized very quickly. Now, symptoms usually are a lump or swelling, feeling of heaviness in the scrotum. Scrotal mass is usually non-tender and very firm, no pain. May complain of a dull ache or heaviness in lower abdomen, perineal area, or scrotum. Acute pain is a presenting symptom in about 10% of the patients, so that's a low number. Signs of metastasis is a late sign, so if the patient's having back pain, cough, dyspnea, or bloody sputum, hemoptysis, or dysphagia, that could mean a late sign that it has metastasized somewhere else in the body. Diagnostically, of course, there'll be palpation of the scrotal contents for a mass. They do use light to flash below the scrotum, and you'll see that the mass does not transluminate. So that can mean that there's something there if you can't see directly through the scrotum and you do it's not transluminating, so that means that there's some type of mass there. An ultrasound can be done, of course, of the testes. And then LDH and AFP and HCG. Remember alpha-fetoprotein in human chorionic gonadotropin. Remember that these are serum tests, and they may indicate a germ cell tumor. And these three indicators, if elevated in the blood, can specifically mean that the patient has testicular cancer present. So these are done often when the ultrasound comes back positive. A testicular biopsy may not be possible because of the risk of spreading cancer locally. So they try to just do a palpation, they'll do an ultrasound, and then they'll do these blood tests. They will also order for a chest x-ray or CT to make sure that there is no metastasis. Treatment is usually a surgical removal, orchiectomy or radical orchiectomy. Post-surgical considerations that need to take place are increased fluids, risk for infection, discomfort, teaching. Also, prior to the surgery, it's very important that you talk to the patient about sperm banking. It's a cause after treatment may be infertility. So post-op obviously could be infertility, and they would want to do some sperm banking prior to, if they wanted to have children in the near future. The patient may require to have radiation or chemotherapy. And it says testicular germ cell tumors are more sensitive to systemic chemotherapy than any other adult solid tumor. Considerations: opportunity to discuss fertility and sperm banking before, and psychosocial issues, feeling of maleness and self-worth. This is very important to the man, and the man may not express his feelings to you, especially if you are a female. So it might be good if they are given some information from maybe a male physician or a male nurse, or even just given a name of a support group. It's very important that we teach early recognition, so the men should do testicular self-exams, TSEs. Normal feelings are like the testes usually feel pretty smooth, and they feel almost like a hard-boiled egg. That should be the normal feeling. Exams should be done every month, beginning with puberty, especially with history of undescended testes or previous testicular cancer. It's important that we use matter-of-fact attitude with teaching, and that we express that all lumps should be investigated. Okay, doesn't mean that all lumps are cancer, but it's important that they get them checked out. Please review testicular self-exams in your textbook. It's very important that you know the best time for the patient to do this, when to do it, how to stand, and so forth. Thank you.